People who are on the phones, or on their computer, if you would please make sure that you are muted and not on hold. So it comes across loud and clear in this big room if you don't mute your phone. So please try to remember to do that. Thank you. Okay, so here we go. Welcome to our second meeting of the Safety Net Committee of the Behavioral Health Task Force. And I'm Nancy Jackson, serving as your co-chair, and Robert is not here. He's elsewhere. So I get to kind of host this meeting. I want to welcome you to the CCI building as well. CCI is Colorado Counties, Inc., and in this room, usually when I'm here, because I come here at least once a month or more, the people sitting around the table are commissioners, county commissioners from across the state. And in this room, we make comments on and vote to support or not support or modify various pieces of legislation. So there's a lot of business from the county's perspective in this room. So so welcome to the county space here. And I'll say we are really glad to have you. I understand that some of you had trouble figuring out how to park, but I will assure you, once you kind of take a look around at the space, you'll find that there's ample parking on the back, and it's pretty easy to come down 8th, turn into the alleyway, and there you are. There's plenty of parking. So just for next time, in case we meet here. That being said, one other thing I wanted to tell you about CCI is that I have the honor of chairing our Justice and Safety Committee. So I get to sit in this chair once a month or so and convene the earliest meeting, 8 o'clock meeting for that subcommittee or that committee. So it's a pretty comfortable space for me. So anyway, we are welcoming you, and I think we're going to take just a quick minute to do introductions. We went into more lengthy introductions the first time around, but maybe this time we just want to say who you are and who you're representing, and that way we'll eventually get to know one another and a little bit more about each other. Yeah, I think that's about enough of that. So you want to start right to my left here. Oh, and then we'll get to those of you on the phone.
Hi, Camille Harding, Division Director for Community Behavioral Health within the Office of Behavioral Health. I'm here on behalf of Robert Worthline.
Good afternoon, everyone. I'm Summer Gathercole, Senior Advisor for Behavioral Health Transformation at CDHS, and probably the person that you are hearing from most these days. So thanks for all your patience.
Afternoon, Kevin Duffy, Douglas County Sheriff's Office.
I'm going to interrupt just a half a second and say, if you use your microphone, press the little button and it'll go on green, and then that turns on the microphone, and then you can turn it back and it'll turn it off. Thank you.
Sarah Vane, Assistant County Manager for Summit County Government.
Aisha Rousseau, Director of the Office of Disability Rights for the City and County of Denver.
Jessica Sharp, Carson County Public Health and Environment.
Frank Cornelia, Deputy Director and Chief Strategy Officer at the Colorado Behavioral Health Care Council. Sorry, new title, getting used to it.
I'm Christina Daniel. I work for Advantage Treatment Centers, and I'm also a city councilor in the city of Alamosa.
Lauren Snyder, State Policy Director with Mental Health Colorado.
Madeline Rubel, Deputy Director of Communications for CDHS.
Barry May, Deputy Executive Director at Colorado Department of Human Services, overseeing health facilities.
Michelle Barnes, Executive Director of CDHS.
Amber Pace, Director of Integrated Behavioral Health for Centura.
Deb Ruttenberg, Director, Grand and Jackson County Human Services.
Rick Sims, I'm a CPA and I have my own firm, but I've been on the board of the Mental Health Center of Denver.
I'm Marilyn Fawcett. I'm a parent advocate. I have a son with disabilities receiving services. Just have one request. Just please spell out your acronyms, as I'm not familiar with all of them. Thanks for that.
Kim Gonzalez, Los Animas, Huerfano County's District Health Department, Executive Director.
Hi, this is Stephanie Kirshner. I'm also from the Farley Center, and I think we'll turn to subcommittee members who are joining us by Zoom. You may need to unmute yourself to join the room.
This is Tom Manzione, Clinical Director at Attention Homes.
Hi, Tom. We can hear you. Thanks for joining. Ava? All right, we'll look for her, and hopefully she'll be able to join audio. If you're having any trouble, Eva, you can chat into the chat box in Zoom, and Emma is monitoring that, so we can get back to you to help you with any technical difficulties. We also have Joy Hart. And Joy?
We're also working to get Allison George from DOLA on the line as well.
Okay. All right. I may have to sit because I don't think I can stand like this. I guess I can, and I don't have a long enough cord. How about oh, here we go. Can you guys hear me if I stand? Feels better. Thank you. So objectives for the day are really just to learn more about the work that we had started on the first time we were together. I will confess to you that since we last were together, I have been on vacation with my family for at least 2 weeks of that. So I'm anxious to dive back in to really start thinking about how we're going to operationalize this work together. And we're going to learn some more about the importance of person-first language, dive back into Senate Bill 222 and thinking about how to definition, which we will wrap up today and then be able to really finalize through some email contact between the next two meetings and really move on into some more work the next time we're together in 2 more weeks. Go ahead.
2 comments. One is remember to mute your phone. We're hearing some kind of feedback or something. And secondly, before we dive into the objectives of the day, I brought some show and tell. I wanted to show you the Witchy report. You don't have to print it out. You could maybe print the first 30 pages if you really wanted to, which is basically the summary. But I think you'll find it, if you haven't read it, again, just the summary, not all 700 pages, I think you'll find it really informative as we go forward. The second thing is, I know you're going to get harped on this, but remember, I'm a recovering professor. I want you all to do your homework, and that is the bill. And as we go along, there will be other assignments, actually not coming from me, but I'm kind of going to be the enforcer. So, yeah, be sure you read it, and, underline it, write notes, all that stuff, so that when we get together, you have that background. So, that's what I brought that for. Show and tell.
The enforcer has spoken. That's good. I think today, as we get into more content related to Senate Bill 222 and some of the work that we're going to be doing together as a larger group, it's going to become even more essential that we think about using this parking lot process that we sort of used a little bit in the first meeting together. We're finding it pretty useful in the other subcommittee meetings to really capture important, but maybe not kind of timely comments that are coming in from the subcommittees, things that we need to follow up on, things that might be really good agenda topics for future meetings, things that are just important to you but not of business for today. So you'll see sticky notes on the tables, and there's parking lots on either side of the room. You also just hand them to us if there's things that you want us to be thinking about. And I may be gently reminding you to put things in the parking lot. I've started doing it in every meeting that I'm in, even at work. We've started using the parking lot, and people are starting to wonder if I'm a little obsessed. But it's working really well to be able to capture some of those issues that are important, but we can't really get to today. We do need to approve the minutes, and Nancy was going to lead us in approving the minutes from the meeting. They have been posted on the website, so they are there for the public to see.
And I'm wondering, any questions or comments or concerns about the minutes? If not,
I had one potential correction,
Sure.
sorry. It may not be an error, but in the quote right under greetings and introductions, it says an integrated behavioral health mode, and I'm assuming that was supposed to be model. Yeah.
Very good. Good catch.
Yeah, and my name, Christina Daniel, just wasn't on the list of attendees, and so that could be added. That would be great.
Any other corrections or comments? Okay, then I would entertain a motion to accept approve the minutes as amended. Okay, Captain Duffy. And Sarah, right? Okay, Sarah seconds. Any more conversation? All in favor?
Aye.
On the phone?
Aye.
Great, thank you. Any opposed? Okay, minutes approved.
Great, thank you.
I just wanted to let everyone know that we also have Barbara Drake, who's a member of the executive committee overseeing the task force on Zoom as well.
Welcome, Barbara.
So before we get started again, we just wanted to bring back the group agreements that this team discussed and agreed upon the last time we were all together. Really, the major addition was around the use of person-first language. Did Aubry join? Oh, she's here. Great. She's going to be able to talk a little bit more about the importance of person-first language and share her experience with this subcommittee today. But that was the big addition to the group agreements from last time. We're really finding that the stepping forward piece of this in subcommittee is something we're needing to remind people. You were chosen to be here as a voice to represent where you come from and the work that you do from many, many, many people who really want to hear from all of you. And sometimes it's also going to mean those of us that are a little more comfortable and chatty need to think about stepping back and leaving space for other people to have a moment to step in. So we're going to kind of be reminding people of that as we go forward through these meetings so that we can make sure that we hear from everyone. And we're ending on time so that Kevin Duffy can get home by 5:30. Now I want to meet your wife. So with that, I can pass to Summer. She was just going to do a little bit of overview of expectations and guidelines document and a few other housekeeping tips or tips. Items.
Thank you. So I just wanted to touch base because we went over this very briefly the last time. Some of you dropped off your expectations and guidelines document today. Thank you. Some of you turned it in last time, which is great. If you have not yet turned it in, I can guarantee you that you will be hearing from us very shortly. But one of the things I wanted to point out, because a lot of people have asked me over the last couple of weeks, well, how are we making decisions? How does this all work? And that is spelled out in your expectations document. So I would I would suggest that you read that carefully. But just to kind of bring everyone up to speed real quickly, if you are not able to attend one of these meetings, and you can attend virtually or you can attend in person, both count the same, but if you cannot attend at all, you have the option to identify a substitute or a proxy. So what that means is that if you have someone that you want to send in your place as a substitute, you can do that. You just need to email us ahead of time and let us know that, so we have that on record. If you know that that particular day we are going to be taking a vote and there's somebody else on this subcommittee that you trust to vote as you would want, you can give your proxy to them. So you have those, and again, that's just something you need to email and let us know ahead of time so we have it for record. But that just gives you a little bit of leeway around, you know, if you can't be here but you still want your voice to be heard, you have those options. A couple other things around how are we making decisions. So we're loosely following Robert's rules. So if we're going to put forth a decision to vote on, somebody will make a motion, somebody will second it, then we'll open it up for discussion, comments, questions, and then we'll make a formal vote. So just so everyone knows from that perspective. To vote, we're just following, we're keeping it super easy. To be able to vote, we just need to have a quorum, which means that we have to have 14 people here, 50% of the, over 50% of the subcommittee, so we have to have 14 people here, and then the majority vote wins. So we're keeping it super simple. I know that there's a lot of different groups that have done it different ways. We're going to keep it simple. However, if there's not consensus, the group that's in the minority has the option to kind of write up their point of view, their response, and that is something that we can include in the addendum in the final report when this work is coming together at the end. So that way your voice is still reflected, even if you weren't among the majority vote. So that's just a little bit of kind of the process so everyone understands that moving forward. Any questions? Okay. Yes. Okay, so several of you received an email invitation earlier this week and just wanted to explain a little bit more. We are having community conversations around the state, and part of the reason for that is because we had 500 people apply for the task force and subcommittees. Obviously, we didn't have space for everybody, and we want to make sure that everyone has an opportunity and a chance to share their voice. So as I'm going out and about across the state, as Michelle and Barbara Drake on the phone and other executive committee members are going out and about across the state, we're really just trying to have what we're calling community conversations. And those are, a lot of times there are meetings that are already taking place amongst behavioral health stakeholders in the community where we can go provide an overview of the behavioral health task force, ask a little bit at the local level, what are the recommendations or solutions that they would offer to the task force or subcommittees to consider. We want to extend the invitation to all of our task force and subcommittee members for you all to do the same in your own communities. So we are having a training, can you hit the button again? We're having a training on next Wednesday, the 21st from 11 to noon. It's just a webinar. It will be recorded, so if you cannot watch it at 11 o'clock on Wednesday, we'll send it out afterwards so everybody has it. But that way you will have kind of the PowerPoint presentation that we're walking through, the talking points, the questions that we're asking, and a little bit more guidance. And so you can feel comfortable kind of teaming up with some of your other subcommittee and task force colleagues to have those community conversations across the state.
Yeah, I promise I won't talk all the time, but I just want to say that Summer, thank you very much, came out to a small, I have a coffee with a commissioner every month, and Summer came out. We also had a rural mental health there, and you know, it wasn't a great big crowd. I'd wish for more, but they were really engaged and very interested, and I got a lot of questions back. So I think as the work of this group continues and expands, we're going to get a lot more people involved. So I think this is a great idea. So thank you, and thank you for coming out to Aurora.
My pleasure. Anything for you, Nancy. But I will say too, I think as we're getting off the ground right now, it's a lot of just information sharing around what the Behavioral Health Task Force is doing. As we get into this work, it's going to be a lot more of, here's what we're thinking. Tell us, is this going to work in your community? Is this not going to work? What else do we need to be thinking about? So it's going to get even more interesting as we go along. Yes. And then finally, public testimonies. So we are offering at least once a month through the end of the task force an opportunity for public testimony where each of our executive committee members are hosting a public testimony where family members, consumers, anyone who wants to kind of share their experience and share some recommendations can come and kind of present that to the executive committee. We will be pushing out, you can see here that we've got a couple of scheduled, Wednesday, August 28th, Tuesday, September 10th, Wednesday, October 23rd. We've also got Monday, November 18th. We will be sending all of this out to all of you on Monday and asking you to push it out to your constituents, especially the family members, consumers who we want to make sure have a chance to share their voice as well. Michelle.
Can I just make a strong request? It'll be really awkward if it's public testimony and one executive committee member sitting there. It's for all of us to hear their voices. So as we're going forward in our work, we're keeping these people impacted in our hearts and minds. So I would love for you to join for any of these. Please come and be part of this listening session. And you're welcome to any and all of them.
So we will send out meeting invitations for those so that they are also on your calendar. And there is the opportunity to participate remotely for those of you who want to do that, so you have a chance to listen in. And again, as executive committee members are going around the state, we're going to be offering them in different areas as well. So for instance, Michelle is going to be in Durango in early October, so we are scheduling, in the middle of scheduling a location for a day for that. So we will send that out to you as well. Great. Oh, go ahead.
If we reach out to members of our community, especially those members who have maybe been involved in the mental health process or engaged in it in somehow as a client or a patient, is there a skeleton type thing that we could provide them, saying that, you know, if I ask someone to come in and share with us that this is going to be public information, it is going to be documented and that kind of stuff, do they need to sign any kind of ROI or anything, or have an understanding so that they know what they're, you know, that they're sharing with us? Because some of it could be confidential, that maybe they might not understand the scope of this, that their story could then be shared almost statewide.
So that's a great question. On the invitations that are going out, it does kind of say that this is public and it could be recorded or used. There could be media present. If we are in a situation where someone says, I don't want this recorded, I don't want this on the record, I mean, we'll ask the media to step out. We'll work with them on that.
Okay.
Any other questions before we move on? All right, thanks, Summer. I also want to take a moment to welcome the members of the public who took the time to be here today, who also found parking downtown and came to join us. And we are trying something a little bit different to think about some time management and trying to put the public comments a little bit earlier so we make sure we preserve time and then only use the time we need. So is there any comment, question from those of you that have taken the time to be here today? All right, well, thank you.
That might also include folks on the phone.
I have a question. Someone asked if comments provided in Zoom could be captured as part of the official meeting minutes.
Okay, great. Thank you for being here. So with that, Aubry Boggs has volunteered to talk with us a little bit about using person-first language in the work that we do both inside and outside of the subcommittees. Aubry, you want to come up here, and then you can kind of, if you feel very far away, and we'll give you the time that you need to talk about your handout and your experience.
And Aubry, before you get started, I'll also share that Megan Lovelace is also a subcommittee member, is also on the phone as well.
Hello. So when it comes to person-first language, it isn't always something that comes intuitively to folks because we have a culture that speaks really poorly about people like myself, people living with mental health conditions. But the way we talk about myself and our community directly affects both the care that people receive, their ability to find and access recovery, and to feel hope at all. And on this flyer that they're passing out, there's a few examples. The first one I always go to is, we would never call someone with cancer a cancerous, right? Like that seems pretty basic, but we regularly call people schizophrenic. I have OCD, and it's interesting because nobody calls me an OCD, or it's interesting how we kind of pick and choose which conditions get those labels. And I always recommend that folks assume to use person-first language before they talk to someone. And if someone says, however, like I describe myself as an addict, if someone uses different language for themselves, always respect a person's individual language choices. I personally abhor language that casts my mental health condition as something that is who I am, because it's not. It's something I live with. It's a part of who I am, but it doesn't define me. I also really want to mention the mentally ill, which is the most common one I hear, like on a daily basis. That is an incredibly othering phrase. It says, you're this group of people over here that we're going to pretend are separate from us and different from us. And if you listen to the news at all, if you watch any media, I'm sure you've seen how people use the phrase the mentally ill to further stigmatize, especially when it comes to violence, the assumption that people like me are more likely to be violent, which is factually incorrect. People with mental health conditions are no more likely to be violent than anyone else, and in fact, more likely to be victims of violence, 10 times more likely, in fact, than anyone else, than other folks. So I always recommend going with the person first, and when talking about people with mental health conditions, that's the term I use, people with mental health conditions. Some people use the word illness. It doesn't bother me quite as much, but I do think a conversation that we've had a lot when I was, well, I guess technically I'm unemployed this week. Last week I was at the network. Next week I'll be the new Ombudsman for behavioral health access to care. But at my previous place of employment, we would talk a lot about how illness language insinuates that someone can't live well. I consider it a condition, just like I have fibromyalgia, that's a condition. And it's not something that is always negatively affecting my life, but it can. There are times when I might be, struggling more with my mental health or other conditions, but illness usually insinuates that someone is sick, that they need, that they're always going to be sick. So yeah, kind of a little overview of why we like talking about person-first language and why it's really important to consider the way we talk about folks. One other note, I always think this is interesting. John Hopkins, I believe it was John Hopkins, did a study last year where they were looking at how the way doctors wrote about patients in their notes, how that affected the care they received. And they were looking at issues around pain, and they found that the more stigmatizing language that was used in the notes, that the person who read the notes and then treated the patient was more likely to give them negative treatment, to not be very encouraging or helpful in their treatment. So just to show that this does, and a lot of people think, oh, language isn't that big of a deal, but it really is. It directly affects how people are able to access care, the quality of the care that they access, and their ability to live well.
Aubry, I have a quick question for you. Sorry. I've heard, I think internally from different advocacy organizations, the use of the word consumer. Do you have a perspective on if that is person-first language, or is that what we should be using, or is it okay to use that language?
It's a difficult one because it is so widely used. I personally don't like the language consumer. I know most folks at the Colorado Mental Wellness Network don't like it because it's kind of shortening a full person into you consume this thing that we're offering you. I feel like there's a lot of different options. Clients, patients, I think are generally better term or obviously. Usually say things like communities. I find that's an easier term to use when talking about folks who might be using certain services in healthcare. But I also know that it's so ingrained in so many systems, it's a difficult one to always be able to break away from. And I have to use consumer language myself in certain situations just because otherwise people don't know what you're talking about and get confused. But yeah.
Hi, thank you for your comments. I am a strong proponent of person-first language, but I would like to hear you speak to the nuance of individuals who are living with disabilities but do not embrace person-first language, and specifically particular demographic populations that hold strongly to not using person-first language, and how you honor and hold space for that.
For sure. I know for a lot of folks that they prefer to be referred to as disabled. While I don't have visible disabilities, that's terminology I use myself. I'm not a person with disabilities, I'm disabled, and I know that seems strange considering that I also prefer a person with mental health conditions to, the mentally ill or a person who's mentally ill. But I think that it's a difficult thing because individuals are always going to have preferences. But often communities come together and say, hey, we really want to use this specific language. For instance, with autism, all my autistic friends prefer to be referred to as autistic, not a person with autism. And I think that part of that is when a community realizes that the way that they've been referred to, when saying something like that could have been considered derogatory before, or even things like an LGBTQ community reclaiming the word queer, that used to be used as an insult, and the community saying, no, like I'm a queer person. I think it's just the most important thing is to listen to folks and to listen to communities and to do research. Like make sure that when you're hearing about how to talk about these things, you're hearing it from the people that it directly affects. I think that it's, if someone says, hey, this person, you should call them this. Obviously, I don't think anyone's really saying that directly, but there's lots of information out there. I think the folks prefer to be referred to as autistic is one of the interesting ones, and I think part of that is the idea that it is not a disability; it is a different brain type. It's just neurodiversity, and I think that is kind of a nuanced thing still in popular culture talking about that, but. From the autistic community, that's what I've heard, is that this is separate from when you're talking about these other disabilities. This is a different kind of thing. There's nothing wrong with me being autistic, whereas, with mental health conditions, and there could be folks who feel that way about mental health conditions as well. I think that there's more the assumption that for most folks, it's not fun to have a mental health condition. It doesn't feel like something that is I've had people describe it as like having a superpower before, like the assumption that because I have OCD, I can, keep everything organized all the time and my house is spotless, things like that, which is not at all true. I wish it was. But I think that with autism, folks recognize like this is a part of how my brain works. There's nothing wrong with who I am, whereas with mental health conditions, they're often the result of trauma, biology as well, of course, but a lot of times trauma is the, big thing that kind of sets off mental health conditions. So I don't know, I think it is a difficult topic, and I always try to remind folks that language is always evolving. It is not a stagnant thing, and treating it like it's stagnant can often end up hurting folks. And if you mess up and say the wrong thing, then just say, I'm sorry, I know better, I'll do better. That's all there really is to it.
Thank you. To that point, are we coming to a conclusion within this space of the language that we're going to use? Is that where we're trying to go with this? Or is this just point of information?
I would just say that from my work and being part of the community and very connected to the community, that the majority of folks definitely prefer person-first language, which is why I say, if someone says something different, if they say like, no, actually, this is how I define myself, then use those terms. But that from what I've heard, that the majority of folks do prefer person-first language with mental health conditions. But obviously, anyone can have a different feeling on that since it's terms describing them. So.
Totally with you. I asked the question because I'm particularly bringing my representation here is particularly bringing to light folks with co-occurring disabilities. And so while I hold space and appreciate that you prefer the term disabled, Within our office, we ask that people not use the term, using the idea that cars are disabled, people have disabilities. And so that's why I'm just trying to understand, are we having this discussion so that we can come to a consensus on the language that we are going to use in this space, or point of information?
Well, my perspective, and Summer, you can correct me if I'm wrong, I would say we wanted to invite Aubry to talk about this because it's coming up in almost every subcommittee meeting that we're having. And it's just a point of wanting to make sure people have information from someone who has the most knowledge about that. And I think in terms of writing recommendations and when things come to vote, it probably will be important to think about how things are worded. And I'm sure Aubry, I shouldn't put words in your mouth, but if she approaches you saying, I would say it this way, I think there's just that grace in this subcommittee that we need to be considering versus being, feeling held back in some way because we're so afraid of what we're going to say that we can't, that you can't get something out. So Summer, I don't know if you would.
Yeah, I would say, I think initially our thinking was to share this as like just some information for all of us to just know and to be thinking about in our work. But if there's a strong feeling of like we need to have a longer discussion around this or come to some agreement or consensus, we can certainly do that too. Do others want to weigh in or share their thoughts or feedback? So why don't we include this like in the we'll do a follow-up question in the survey that goes out afterwards so we can dig into this a little bit more.
I would say too that generally when I always recommend when talking about large groups of people as opposed to individuals, that person first language is just your best bet. Like even when it comes to disability, because the assumption that we know how another person feels about something, unless the community has been incredibly clear about that, like this is the way we want to be referred to. But so I think that's why
I would agree, and that's what I'm thinking. If we are coming to an agreement in this space that if an individual says, I get that all the time, I prefer to be called blah, 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 then we honor that. But in this space, we can at least agree that we will use person first language across the board in order to be relevant and appropriate.
Thank you.
Thanks, Aubry, and we're excited to welcome you to the Ombudsman role. So we'll see you next week. So I just wanted to spend a few minutes to refocus us on the work that we did together at the last Safety Net subcommittee meeting around definition of safety net. And I typed up notes from all of the flip charts and worksheets and notes that you left behind in the parking lot, and created a word cloud because I like them. And it always makes me happy when things jump out that we're like really focused on as a work group. And so we're going to dive into this in a more concrete way, but I really wanted to share this so that you can see the words around access, safety, affordable, community, coordinated, regardless of payer source, which isn't one word, but I made it one for the word cloud. So that I wanted you to see that you're thinking about these things in a similar fashion, even though sometimes the semantics of how you describe them was slightly different. But these are really words that popped out. I'm so happy to share this with you. You'll have it in the slides as well, but I just think it's a nice way of, visualizing how your words came together to kind of create some themes. And so these are the themes, kind of for those of us who prefer a list over a cloud, that we're really thinking about access and no wrong door. That was the one that came out, I'd say, all the time. In almost every single group, there was something related to access. There were a lot of comments about remaining culturally informed in the work that we do and in the recommendations that we make. This all-inclusive theme kind of captured both severity of need and regardless of ability to pay. That we wanted something efficient, something seamless, which is really tied to accessibility, affordable and safe. Workforce was another thing that really, really came out that I didn't include in this list of themes, but certainly was there. And so these are the kinds of things that we're circling around. And I'm standing where Robert would have sat if he had been here. And I think it would make him really, really happy, and Nancy too, if we come out of today's conversation after hearing a little bit more about Senate Bill 222, how that drives the work and informs the work of this subcommittee,
to really be thinking again about definition of what do we mean by safety net, and getting a little bit deeper into that if there are specific services that you think need to be included in a definition, or if we need to take it just one step further than we were able to in our first conversation. So are there any questions about the themes that you're seeing? Shocked?
I have one question.
Yeah.
And this is kind of, so in looking at the agenda for today and trying to, in my own mind, come up with understanding with the term health safety net, and the research that I've been doing, it seems like so much of that, when you look at that term and what it is, everything seems to focus on either the uninsured or the underinsured. And that's kind of where all the focus is on and even a lot of language in the House bill. And I just want to be clear, that's not something is that something that we are primarily focusing on here, but I kind of look at this as a health safety net for everyone. Doesn't matter if you're living in a mansion and you don't have access, or we're trying to get them access, or the person who has no insurance at all, and we're trying to, we're trying to work with everybody. Is that a fair statement? That it's not just the uninsured and the non-insured?
Well, I would say yes, but I can ask our co-chair to directly answer the question.
I wrote down the word cloud, or the list of the word cloud, and one of the things that's there is all-inclusive regardless of ability to pay, and I'm on that team. I think that's what it means, but again, I think I am seeing a few nods, several nods here, that it's everything from, as you say, the mansion. Hopefully they don't need us, but if they do, they do, and Medicaid and Medicare and no insurance and all the different pieces in between. That's what I'm thinking that means, all inclusive, regardless of ability to pay. Yeah.
I think I would agree that individuals fall through the cracks, not people who don't fall through the cracks who are uninsured or underinsured. So for me, it's everyone.
And that's what I was going to say. There's people who live in mansions in rural areas who still don't have access to services, regardless of whether or not they can pay by cash when they walk in or have health insurance.
And I was actually going to bring up rural areas. So, so look at this. Centura covers the entire state of Colorado, and we are seeing a lot of great need in our more mountain communities and then our rural communities. They're getting hit really hard with no access to services, even basic outpatient services, but also crisis services. So I wanted to make sure that we focus our attention on being inclusive of that as well.
I would just echo the rural comment, because we really talk a lot about pay, but living in a rural area, those services aren't there. And even as someone who may be able to afford services as a private or as a provider, when I needed services, they were not available in my community for myself. So.
And I'm also thinking that another piece of that word cloud was regardless of severity. So it's my understanding, and there's something in the bill that I was going to ask about, but I'm thinking that regardless of your diagnosis or your severity, that there are services available. So whether you're moderately depressed or suicidal, there's space for you. That's my thinking.
I don't disagree, but I also think it presents a challenge to the work of this committee and the task force, right? When we talk about various, payer sources, and we talk about a population of 5 point whatever million people, that's quite a task to go from insured, complicated bereavement to indigent and dealing with acute mental illness or mental crises. So it just thinking about, like, again, just saying I don't disagree with the statements, but it does, it challenges us as a work group to get our job done, to be able to parse out the different ways that you address each payer problem, those type of things. So.
So you bring up a good point that I think we need to ask or think about, and that is, are we going to start out with the best of all possible worlds if we don't have limits on us, or are we going to begin with, gee, we have, we can't do everything for everybody. So I don't know what I think that's part of what we're going to define today, but I think, Frank, you bring up a really good point. If I'm wearing a commissioner's hat, I'm always thinking about, well, how much is this going to cost, right? But if I'm thinking about just brainstorming, I'm thinking, hey, in the best of all possible worlds, what would this look like? Not thinking about how much it's going to cost or who's going to do it. I'll figure that out later. So I'm just kind of wondering where we are in that regard. Yeah.
I think Robert said at a few other meetings that the governor's direction was everything's on the table, and I think we should work from that. That everything's on the table, and we should build a system that we want, and then if it needs to be drawn back, then we can do that.
There we go. I'll second Lauren and add too that we might not necessarily be able to accomplish every single thing, but I think that when we kind of fracture the way we approach the system, it's why it keeps we keep ending up with the results that we've gotten for so long. Is it's always like, well, we can't do that much, so let's only do this much. And I would rather say, what do we want to do, and then see how much we can actually do within that framework. And then we have a vision for the future as well, beyond what we can do here.
Sarah, and then I saw hands up here, but I can't necessarily read everybody's names. So
If you could turn your name text towards us.
even then, I might not be able to read them, but that helps. So, okay, Sarah.
I did appreciate Kevin's question, because as I was reading the act, there's a lot of references to Medicaid, and not that population isn't really important for us to focus on, but I think one of the reasons our system is so is in such a difficult place is because everything's organized by payer source rather than what the person is wanting or needing to prevent a crisis or get themselves out of crisis. And so if we just continue organizing everything around how people pay and what the payers care about in terms of what they're going to pay for or not pay for, I don't think we're going to move the needle on this in any way.
So being rural in public health, we need to look at it in an equitable way, but also we don't just look at payer source, we look at access and transportation access. In Trinidad specifically, to see a psychologist, you have to go 2.5 hours. So that's a huge barrier for rural Colorado and for patients going forward.
Thank you. Did I see another hand on this side? Okay. Anybody else?
Well, I would just add that in the Farley Center work in other states, we've grappled with this too. And starting big with all usually ends up narrowing down to recommendations that need to be prioritized. And so that's where things start to kind of level out in terms of what can we spend? Who do we spend it on? So starting big, I think, we're trying to get to kind of a North Star. Not everything will be achieved, but we can get to as much of it as possible. So going big, I think, in these vision statements and in these definitions will frame the work. And I think it'll also help the work of the other subcommittees as we're traveling across them to really start seeing where there's commonalities that will really inform, ultimately, the blueprint. So I'm just going to add one piece to that and say not everything will be achieved right away. So I think I've talked before that it's all going to be in phases, right? So we're not going to significantly change the system in year one. There's going to be changes that happen in year one. There's going to be changes that happen in year two. And there's going to be a North Star that we're going to be working toward. But it's not all going to happen at once. But it will happen if we really wanted to.
Yeah,
Go ahead, Richard.
I'd just like to add that there's a lot of technology that's coming down that maybe could really help with a 2.5 hour telebehavioral health, but we have to have methods to pay that as well. And right now, I think it's somewhat difficult, but I think if we look at the whole broad thing and look at where technology can really come in to help us, I think there's some real good opportunities there.
I will just add to that, that this morning, I was telling Captain Duffy this morning that we met, Arapahoe County met with Colorado Access and their behavioral health endeavors. They're really working hard on that, and I know that they are only in certain regions, but I think there is a movement towards that. So all things are on the table, right? Including that? Yeah, Kim.
So with that comment, you know, down in rural Los Animas County, we do not have access to internet. And we are the lowest speed, I think, probably in Colorado in certain areas of the incorporated area. And so that's another barrier that we face down there.
So we want to tell you that we discussed that, and there are technology fixes for that. Yeah, you can do hotspotting. There's ways to deal with that. So we can make that happen if we have the will.
So in looking further into trying to draft a sentence or two related to all of the words in the word cloud, we took a stab at a draft definition for Colorado. So on this slide, which I know is kind of busy, but it's also in a handout on your worksheets, we took a stab at our draft, which we are open to you throwing things at and refining and changing and editing. It's just first stab. From the language you provided us. And then we also shared a couple of other definitions from other states and from the Institute of Medicine. And then Frank Cornelia also sent, I think there was one additional definition from the Colorado Health Institute that's also in your handout. So you can start to see that other states are thinking about similar words, thinking about similar structure around what defines safety net. And we can start thinking about if we want to pull some of this in, if some of it doesn't apply to us, if we feel like we're better off with one sentence, if we feel like we're better off with four. It will get into semantics, which I think we'll handle through the survey opportunity so that we're not doing a lot of wordsmithing in a group of 30. But this just gives you a place to look at what other states are using to define their work.
Yeah, I would just add, and we talked about this a little bit at the kickoff meeting, that when looking for a definition, many states or systems define it by the providers who serve, or a population who receives, or a set of services you provide. But what I think we're being charged with is really defining the system and then kind of building the recommendations how to operationalize that definition. And so the one that we could find kind of closest to this visionary system level was from Oregon. And so just really thinking about how to serve those who need services as opposed to the providers who serve for. So it's a little bit nuanced, but just be considerate of that as you read through some of the examples that were provided.
Yeah, and also of note, the Oregon definition is really about healthcare safety net, not specifically behavioral health safety net. So it's kind of all encompassing. So that's just another little nuance that it should be noted there. But we can think about this as you respond. Were you going to say something, Frank? No.
Related to 5 minutes ago, but I think you may just think about. I want to make sure my comments are clear. I agree about everything on the table, about having a system that nobody falls through the cracks. My question is, we got short timeline. We do have timelines laid out in 222, and I know we'll talk about that. That's 2024. The question that I'm sort of challenging the group to think about is how do we operationalize what we're going to do? We have a 700-page report. We have other reports on the shelf. We've made recommendations in the state over and over and over again, and we have done very little to change our system. Providers have been asking for change. Consumers have been asking for change, and we need to think about how we are going to implement what we are talking about. So I agree. I mean, this is a great exercise. We need to have a North Star, but then we need to figure out how to get there. And so then you're going to have to come up with, what are we going to do about private insurance? What are we going to do about Medicaid? Do we have too many waivers? What do we do with all the other funding streams? I mean, some of those things we have to talk about how we're going to get from here to there. And So anyway, I agree with setting the North Star. I agree with definitions. My comments are really about how are we at the end of this going to get something done by 2024, which the legislation says not just you have to define it, but you have to implement it by 2024.
Yeah, and Frank, I feel like you've been on the phone with me and Summer and Emma, because we're excited about moving to those, how are we going to operationalize the work, and it's exciting to think about digging in. We have to get this first step behind us and make sure everybody's on the same page, and then we go. Summer, I don't know if you want to add anything.
Yeah, the only thing I would add is I agree, Frank, we have a lot of work to do in a really short period of time. So that is why we asked everyone to sign that expectations document, because this is a heavy lift and we have a lot to do over the next year. I also would just add and reiterate what I've shared before, and that when we deliver that blueprint, it's not just recommendations, it is the how. It is the, here's the staffing, here's the budget, here's the agency responsible, here's the public policy. Like, there should be no question around every step along the way of recommendations around who needs to do it, how it's going to happen. And that way there is that accountability built in and everyone's really clear moving forward.
And just to share some optimism, the long-term competency subcommittee is one meeting ahead of you all, and we're getting there. We're starting to really dig in, and it really took those 2 level-setting meetings, as painful as they can be for people like me who are just ready to go. It's important that we all kind of are going to have the same North Star, or to be confused later on when we are trying to prioritize the work and come up with something to inform these recommendations.
So on your definition, which I think is very good because it's simple, it's pretty much direct to the point. The only word that I don't see in there that I would just ask the committee if it's something that we would want to put in there, because I would hate to see this committee do all this work and then this plan gets implemented in 2024 and then changes happen, politics happens, and then everything that we've worked on for the past 5 years goes away. So, you know, it'd be simple to say a safe and sustainable community-based behavioral health system, something that can be pretty much locked down it's not going to go away. The work that's being done here in 2019 and 2020 doesn't go away in 2025, 2026. Does that make sense?
Yes.
And I would just say, in terms of, you know, operationalizing everything, I think there's a lot of examples around the state of communities who are working around the current system because it's not working for them, and there are a lot of creative things happening across the state where people are just tired of being dependent upon, you know, whatever the funding flows are and how mercurial those are, and passing ballot initiatives and deciding this is what our community needs and this is what we're going to do. So I think the larger the barge that you try to turn, I think we should be as community focused and specific about what's working as we can. And then in terms of the definition, I would just say that the one piece I like about Oregon, I know it's meant for healthcare, is that it's patient-centered or client-centered or person-centered. And I think that we want those services available for people in terms of how they define that rather than what the system says they need. And I also think it's important the order in which you put those words. And I don't know if efficiency, it's important, but if that's the most important to us, or if it's some of these other elements that we want to prioritize to demonstrate this is what our focus is. It's like sugar being the #1 ingredient. You don't want that. So I think we should be thoughtful about the order in which we place those words.
Yeah, that's great. And then there will, for that kind of thing, the feedback on the survey, you'll have an opportunity to really type it in.
Oh, sorry, Christina. The one thing, I know workforce didn't make it on your list of themes, but one of the things that I really liked about Oregon's vision was that it also said the right clinician in the right place at the right time. We do have a workforce issue in the state of Colorado, and all of from the high level that we want to have, if we don't have people to provide these services, we're going to have a struggle. And so I would love if we could potentially add something about whether it says the right clinician, because I know that fits in there, you know, the way they wrote theirs, but something about workforce would be important to me.
Marilyn Fawcett, I just was wanting to add the word timely to our main definition, because there's so many times you need a bed tonight because this person is hurting themselves or others. So you can't have 2 months waiting period. So I thought we could add that to the definition. I don't know if there's a better word, but just that it's timely. Or when they're arrested, maybe that's the time to evaluate them for mental health and for having disabilities.
That
Do it at
kind
the
of
right time.
That kind of speaks to that Oregon definition with right time, right clinician, and so on. So,
Can we
okay.
just check in
Summer.
with people on the phone real quick, if there's any comments?
Good idea. People on the phone, you have some ideas or thoughts?
Just make sure you unmute yourself before you start talking.
Hi, this is Allison George. I joined late. I apologize for that. I didn't have anything to add. I think that it's a great conversation, and I love the aspect of timeliness and availability.
Well, and this won't be the last chance to weigh in on words that are popping out to you. And if you want to either put them in the parking lot so we can snag them, if you want to wait until you get the survey and give this some more thought and send them in, this won't be the last opportunity to get thoughts out at the table.
Summer, this is Allison. Did you guys hear me?
Oh. Yes. We heard you. Sorry, Allison. Thank you for joining.
Okay, great. I just wasn't sure. Thanks.
Go ahead.
We also have a comment from Eva in agreement that workforce is a major issue. Okay.
Sure. I like the language under Oregon about opportunities for those who would otherwise have barriers to accessing quality health services. I feel like the first definition really misses the boat on this is a system. It's not a providers. It's a system of individuals that keep services that keep individuals well, housing, employment, a community, a sense of belonging to your community that I think I want our definition to include, because we can't just all depend on our behavioral health providers because they can't do it alone, and I want our system to reflect that.
Yeah, go ahead.
Okay. To that point, something our smaller group talked about last time was really trying to expand what our thought is in terms of services, that it's also alternative therapies, that patients know what they need, and it isn't always a one-on-one therapist. And so it isn't always a group, it isn't always a psychiatrist. So really trying to expand our thought process on who it is that we're providing services.
Just had one suggestion about adding the word comprehensive to sort of fit your comments, Lauren, about a safe, comprehensive, community-based, system that incorporates a lot of those other things, and it's not just behavioral health providers.
Okay, we are going to come back to this at other times, but I think this gives our folks some really great feedback for them to come back with the sort of modified definition that we've kind of just brainstormed at this point. But we are moving on now to the next.
Well, and there'll be more time for group discussion after Camille does her Senate Bill 222 overview. I think what we wanted to do in planning for this meeting was really get some of that back in front of you again, to think about if that frames definition, if it calls out specific groups, services, so that we can come back, considering what the language is in the bill. So I wanted to pass to Camille. I don't mind doing your slides. There's not many, so that's great. I don't mind clicking. And then we can open it back up for further discussion and questions for her, and see if we can kind of make this come full circle a little bit. Okay. So you can go to the next slide. So I was just going to do a high-level overview. So for those of you that's read the bill, the first couple of pages are really the legislative declaration that talks about some of the challenges within the current behavioral health system, and some opportunities for improvement. And there's a number of examples, so I don't need to dive into that, but wasn't sure if you'd have a copy in front of you, but there is the link to where you can find it online. And so then one of the major pieces within this is it creates the behavioral health advisory body that's tasked to strengthen the behavioral health safety net system, which you are all a part of. And so specifically in terms of timelines, by July 2021, right, and I know that you're all interested in getting this done by next spring, it's really taking a look at what each community needs in terms of access to services and around each region of the state. So having a good handle on that. One of the things I did want to mention is that we have, at the Office of Behavioral Health, have put under contract Health Management Associates who's going to be tackling our population and needs study. And I think that'll be a helpful tool in they're taking a look at all our existing data sets, some of our existing reports, and it sounds like some of the reports that we're all familiar with that have been produced over the last several years, and trying to consolidate it into one sort of set of this is what we know about the behavioral health system, and I think they will be working with the committee to help us have some good data to leverage for these conversations. And one of their tasks that I have given them is that they're going to be looking at population estimates by county, by region, and what is that sort of minimum standard of services that each provider in each community should have, right? We know there's big gaps in rural communities around access to psychiatry, and probably don't have access to a child and family clinician, right? And probably don't even have outpatient services without traveling some distance. So really kind of thinking through that continuum. So I think this will be a useful tool and that we can leverage. And so then the next piece is to develop a funding model to ensure viability of the safety net system. And then also providing local recommendations to address issues related to licensing and regulations, housing, transportation, workforce, and barriers to care, right? So this is obviously a huge amount of work, and each one of those things could take a lot of time. So that's the first piece of it. If we want to go to the next one. So then the next big piece of this is requiring the safety net system implementation by January 1, 2024 to include some criteria around the safety net system not refusing to treat clients. There's lots of language in there around ensuring that you treat individuals with aggression, physical, intellectual, or developmental disabilities, multiple system involvement, children involved with child welfare, at risk of becoming involved in justice systems or criminal justice systems. And so making sure that there's capacity and services to treat those individuals that may need that level of care. Program management strategies for individuals that are hard to serve, case management and care coordination throughout the continuum. And that requires a lot of outreach and community-based services that look different than the service delivery that might happen currently in some cases, or that type of care can be delivered in our current system to a handful, and we know that there's probably some fair amounts in that need. And then the next piece is really outlined in this particular section, training and competency for staff. One example of that is building skills for clinicians to be able to de-escalate an individual that may be aggressive. There's other examples of what that might look like. Evidence-based programming and quality services, and then language around network adequacy and really understanding what an adequate network would look like. And then there's a requirement that there's annual reporting at SMART Act hearings beginning in 2022. And the next slide. So the next piece that I'm just going to outline, there are some specific things that are called out for healthcare policy and financing, and then also within the Department of Human Services. And so healthcare policy and financing is tasked to develop measurable outcomes to prevent Medicaid clients' involvement in criminal or juvenile justice systems. And then there's some language related to incentives and strategies for providers to serve individuals with severe treatment needs.
And then there's language around exploring an 1115 demonstration waiver. I put a link on that particular activity to a CMS Medicaid medical director letter that went out in November of 2018 that outlines some strategies that might be helpful to look at. I can also get copies and send them along next time as well if that's helpful. But it gives lots of examples, and some of those examples, actually let me turn to the right page. So some of the examples outlined are integrated services, looking at primary care systems, looking at interoperability and combining different data sets to be able to really make sure that we're looking at the right set of services for particular populations. There's suggestions around registries of both provider registries as well as registries to help get individuals connected with services. And there's some suggestions around the MIDA 3.0, which is a technology solutions for those of you that don't read interoperability documents for fun. And then there's also language around increasing access to crisis stabilization services, and then making sure that there's appropriate intensive acute services in communities and making that more fluid in some language around that. And then it called out specific opportunities for federal match. So that's a good document to kind of, I think, at least wrap your head around some examples about some places that there is some guidance, just even for familiarity, but it does, that piece of the work does fall through healthcare policy and financing. And then it tasks the Office of Behavioral Health to develop admission criteria for access to civil inpatient beds at the state hospital in Pueblo and then also at Fort Logan. Historically, that was geographic and largely the community mental health centers and formerly the BHOs had access to those beds. And so it's making the Office of Behavioral Health put in some clinical criteria around who has access to those beds, and that's actually drafted, the policy is, and I think it should be public, and I can also bring a copy of that as well if you're interested in looking at it. So I just summarized what's in there because I didn't know the level of depth that everyone has gone through the document, but I'm happy to answer questions and sort of flesh out any areas that seem relatively gray, at least those places that I can. Well, this is here from Healthcare Policy and Financing. She can probably talk about the Medicaid work.
We've got a question way in the back there.
She's waving at me.
Oh, you don't have a question?
Melissa, Healthcare Policy and Financing.
No questions? It's all crystal clear?
I don't know if this is exactly a question, but I wanted to emphasize that this is for behavioral health disorders. So for instance, my son has fetal alcohol syndrome. He was born with that. It's brain damage. And a lot of them end up in jail. A lot of them are not diagnosed. So I just wanted that clear because I noticed it says behavioral health disorder. I don't want to stop, just focus only on mental health. And actually a lot of these people tend to have some mental health issues too, but we need to remember that a neurodevelopmental disability needs to be included. I just wanted to point that out. I sort of circled that here. And then I also heard about, it's pointed out that we want to keep people out of jail that really need to get services. And unfortunately, many of these people are they're not diagnosed. And so that's one thing that I'm going to kind of focus on. It's not just treatment, and these people don't know what they need. Somebody had mentioned a lot of people do know what they need. My son, he doesn't want to even admit that he has a disability because he doesn't like it. And yet he doesn't live independently. He gets a lot of services. So just the fact that we also have to evaluate and diagnose. So I'd like to get into detail eventually on when that might be a good time to get into details. But I just want to point that out. Thanks.
No, thank you. I think that's a really good point. Oh, yep. Sounds like someone else is going to make a comment on the phone.
Hi, Camille. It's Allison. You know, and to build on that, TBI traumatic brain injury. I didn't see that specifically addressed, and that seems to tie really closely with the fetal alcohol syndrome conversation. So I just wanted to put that plug in there. But my question was specifically on triage individuals, so page 10 of the bill, Roman numeral 5, triage individuals who need alternative services outside the scope of the safety net system. I was curious what that was and if that might include like tenancy support to help maintain stable housing situations, or if that was referring to other things, what those things might be.
Allison, can you tell us a little bit more about Roman numeral 5? I think there's more than one here.
Oh,
it's
really?
Okay,
on page 10? Yeah, on page 10. I apologize, I'm driving, so can't dive in too much into it, but
yeah, Allison, so Summer actually just pulled up that section where you're looking at, and yeah, it looks like that's some of the implementation strategies is really being able to triage and identify alternative services that might be outside of what I'm assuming to be traditional sort of behavioral health services. So I'm sure it is housing, transportation, all your social determinants of health, and making sure that folks have access to the set of services they need to be healthy. And that's important in making sure in treatment that you want to make sure that you have all those other adjunct sort of services in place. People can be successful.
Okay.
And I'm imagining that is one of the components. Yeah. And then can I just go back to Marilyn's comment about individuals? Right. I think that when we think about designing systems, right, we are thinking about designing them to be inclusive and include individuals with traumatic brain injuries and include individuals that, right, have comorbid conditions, and that's always going to be one of those factors that you're considering when we think about system design.
And can I add that I know you were going to review the statistics. I don't think they exist. So that's an issue. Find out how many children or adults are exposed to fetal alcohol syndrome in Colorado, or have fetal alcohol exposure in Colorado. Nationally, it's up to 1 in 20, and part of that study I found out was done in Colorado. But since so many are not identified, when you have this group look at the statistics, can you add that in there, please? Even if they don't exist, maybe get some stats.
Yeah, so I was just going to mention, so I've seen sort of the high-level framework they've put together, and one of those places is that they are looking at systems and programs around the state that serve individuals with a disability. And so we're going to have to refine what that looks like, right? And there's not going to be one way that you treat a particular patient, because it's dependent upon, right, like all sorts of factors when you're treating someone. But I anticipate that they will end up coming to this meeting and probably giving some basic information. And in lots of cases, we end up doing population health estimates, right? So we know from public health data sets, the behavioral health risk factor surveillance tools, about anywhere from 15 to 20% of individuals in the state may have an unmet behavioral health need. And so when you're looking at maybe 20% of individuals need services, and in some cases it's higher, right, depending on geography, our system is probably built before the Affordable Care Act, and the Affordable Care Act and healthcare coverage has necessitated more service delivery around the state, because it's increased coverage, and now we need more access. And so I think that that's a place where, right, we have a challenge that we're trying to catch up with some policy that's really important, and we now need to make sure that all those pieces in place in communities are effectively functioning to serve individuals. So there's lots of work to do.
Do we have a question in the back?
Sure. It was mostly to respond to your issue with the fetal alcohol syndrome. On page 5 of the bill, there's a definition of behavioral health. Basically refers to an individual's mental and emotional well-being, development, and actions that affect an individual's overall wellness. problems ranging from unhealthy stress to a diagnosable and treatable disease that are all encompassing in the definition of behavioral health, and includes, but what is it? An intellectual or developmental disability is insufficient to either justify or exclude a finding of a behavioral health disorder. So we thought that that was sufficiently broad enough to include anything that really affects your mental well-being would be included in a behavioral health condition. Page 5 of the bill? Yeah, I had that. Okay. What I would have liked to see added is
I have a question in regards to the bill, kind of referring back to what we just talked about on page 8, when it says then July 1st, 2021, the department in collaboration with the advisory board shall develop a comprehensive proposal to strengthen and expand the safety net system that provides behavioral health services for individuals with severe behavioral health disorders, referred to in Article 63. So I mean, out here it calls for severe behavioral health disorders, language I've seen somewhere else. So I guess conversation for all Coloradans, but here it calls out severe. I don't know if there was clarification or anything in terms of that.
That was my question too.
I just want to let you know I had that question too. So there's several of us who have that question.
And it's actually in conflict with our original statement where we talk about regardless of the severity, and then it clearly says it has to be severe behavioral. And for a novice like me, what is the definition of a severe behavioral? I don't know what that is. You know, I don't think the people who wrote this probably know what it is. They just, you know, what is severe?
I say, doesn't insurance companies have a definition of? Well, that's I remember working as a case manager. There were certain diagnoses that were in like a severe mental health.
We've got a possible answer here.
Yes, so individuals diagnosed with a severe mental illness and SED, severe emotional disturbance, which has historically been used for kiddos, comes from Substance Abuse Mental Health Services Administration, so probably some of that language ended up in this bill. I'm on the Child and Family Subcommittee, and that same sort of question has come up where the bill has some very specific directives, but the subcommittee is thinking about what the delivery system for kids and adolescents needs to look like collectively. So I've thought about it as both, right? This bill has some very specific things that need to happen for to be really tactical in nature, to ensure that we have safety net systems in place for an individual with a diagnosis that's severe, as well as the system itself, and thinking about places around the state where there's not even coverage, there's not an adequate network of providers. So it's both, it's not either or. So I think that's how do you think about the levels of the continuum that need to be in place in communities. Also, what might be helpful is just a quick sort of review of what I think historically the community mental health centers have been really thought of as the safety net system in a variety of places. And so statutorily, community mental health centers are tasked with 5 activities, right, which is the full continuum of services. So it's consultation and education, outpatient services, which you'd think about as your traditional sort of 1 hour a week, go and see a therapist, also the emergency services that are provided by a community mental health center. And we also have the crisis system that interacts pretty closely with emergency services. And then also in the definition, there is partial hospitalization programs, which is not really anything that's done it's an old CMS definition from about 30 years ago. And so we've sort of translated that into intensive community-based services and thinking about what that level of intensive services someone might need when they need that level of care, and then inpatient levels of care. And so when you think about that continuum, you want to make sure that every community has that set of services, but expecting every community to have that full continuum under one umbrella is really challenging. And so that's where you have to start getting creative and thinking about that, because there's all sorts of factors that play into that. So it might be helpful to look at that and consider, right, that framework, and if there's additional sort of pieces that need to be built into that statute.
I'm looking to see if anybody else has questions.
I do want to pivot a bit, not to stifle conversation or cut off questions, but thinking about this and what Camille has shared around alignment with the work of this subcommittee. Because I think that really, in my mind anyway, ties pretty clearly back to definition, so that we can really be thinking about, are the way that these things are being defined in 222 aligned with our definition? Does the subcommittee feel like they have a clear understanding of alignment between Senate Bill 222 and what this subcommittee is supposed to do? And so that, I feel like if we can have a description of that, I think that would really help, and also for me lead to a more, the definition becomes even more concrete. So I don't know, Camille, you're nodding. Do you have, are you?
Yeah, we're looking for feedback on that question. It's our previous conversation around the definition, at least trying to take a stab at it in the word cloud and all that. Is that in sync with what you have read and understood to be in the Senate Bill 122? What do you think? Are we on the same path, or do you see divergence or issues or problems? I think the question of severity in the bill, I think, was responded to, so it's more in line with what we're talking about. But are there other issues or questions or definitions that you found problematic as you read through this? See, I told you there'd be a test.
Yeah, I guess I have one question. I'm just wondering, in terms of looking at network adequacy, I know that means a lot of different things. And then when you think of the workforce, do we have any sense for the state as a whole what the delta is between, say, let's say you just take outpatient services and the metric is you want people to get in within a week, which I know rarely happens in a lot of places, or at least not in our community. Do we know where we are versus where we need to be to be able to say mission accomplished on network adequacy?
So I will take a crack at this. So when we talk about network adequacy, I always think about it as a payer sort of network, right? So Medicaid has a network, they have network adequacy requirements that are in federal regulations. And then also United Healthcare, Aetna, all of our commercial payers also have network adequacy. And so I think that they probably have their own definitions about what that needs to look like. And usually it's a distance that someone may have to travel, time and distance factors. And so I think that the way you approach it is probably both, right? As sort of the floor by community, what do you need in place? Because we know there's big geographic regions around the states that don't even have a primary care provider, let alone a psychologist. And so I think, at least how I conceptualize it, you guys can have this conversation, is both of those things, right? Your payers are going to have their network adequacy requirements, and then we need to sort of set the floor and think about strategies to build capacity in communities. Because
maybe you have a provider that's 5 minutes from you, but they're not taking new patients,
right.
Or they'll take a new patient, but they'll only see you once a month.
Right. Or you've left, 30 messages to identify a provider because you have commercial insurance and you still can't find someone. Yeah, there's all of those different examples, and thinking about how do you scale capacity in communities, because you're not going to just create a new workforce. That takes some time.
I still have a high concern that this committee, and with the level of expertise that this room has thrown so much out there, and the way I understand the structure of this task force and the subcommittees is we have the primary task force, and then we have our subcommittees that are answering to the task force. And I would ask, and my understanding is the chair people on this subcommittee then go report to the task force. I think we need some clarification before the next meeting on that. They threw that one word in here, severe, right? That so much of what we've talked about wouldn't be classified in the behavioral health as severe, but we all are in agreement this is important to be in the health safety. Don't let us go down this rabbit hole and then come back 4 months in the work and say, oh, well, you guys missed the boat. It was only severe, and that's all you should have focused on. I think we need some direction from the primary task force to say, this is what the subcommittee is talking about. This is the direction they're going. I think we need to be reined in.
Thank you for that. It's my understanding that we will present our kind of straw man definition kind of thing, which includes that inclusive definition to them, and then get their blessing on that. And then we can also do a little deeper dive, if you will, with them to make sure that even though it's mentioned once or twice in the bill, that we have the purview to go broad and be everything to everybody. Yeah. Oh, I'm sorry.
Nancy?
You first. Yes. Is that Allison?
Yeah, this is Allison. Thank you. I just wanted to add to that. I mean, I think
we lost you, Allison.
I think you've disappeared, Allison. Meanwhile, is that Deb? Okay.
On page 9 of the bill, there is a tiny bit more information about that whole acuity level and severe or not, where in A it says the safety net system must not refuse to treat an individual, including use based on the following, and then number 2 says the individual's clinical acuity level related to the individual's behavioral health disorder. So that to me kind of talks a little bit more like the safety, our safety net system that we're developing shouldn't refuse to help anyone regardless of whether it's severe or not severe. So I mean, it's not very clear, but there's a little bit more language in there.
And I think getting clarity from the task force would be helpful, just because of just to make sure. Yeah, go ahead.
I think everyone can blame me for this confusion. Mental Health Colorado helped draft the bill, and it was kind of a tight timeline when we did have drafting authority and we didn't, and yeah. So at least from us, from the main drivers of the bill, it was our intention that we just wanted to make very clear that the most complex, the hardest to serve individuals would always have a safety net, but that the safety net would be open to everyone. But we just wanted to really drive home that the hardest to serve individuals that we're seeing fill up our jails would have a place to go, because those are the ones that we've seen the biggest issues with, co-occurring conditions, kind of homeless individuals certifications that drop, et cetera. But that we imagine it would be the broad range of individuals, not just those with severe mental health conditions.
As a politician, I say it's always helpful to have somebody to blame.
We would never blame Mental Health Colorado. Nancy and I will take this back immediately because we're both on the executive committee and heard your question. But my understanding from the governor is his direction, which is slightly different than the bill, is all Coloradans, not just the most severe. So, but I will confirm that, but I can't imagine we would be leaving out. We're looking at all Coloradans, so I agree with Lauren.
Well,
we don't want people to get severe. I mean,
the way to keep that from happening, that's what we can do. A couple more. Yeah, go ahead.
So when we're talking about going back to the definition and looking at whether or not we understand the bill and how that fits in there, the place where I got maybe a little stuck, I totally agree with not discharging clients for us, for the providers. I think, figuring that out is one thing. But when the clients choose not to be a part of the system, when the clients have their voice and choice in this, I feel like we didn't say that in our definition, and that's also important for, I think, people with behavioral health concerns in the whole gamut. If they don't want services, we can't force them to get services. And so how do we, when we talk about this as we're going forward in our definition, how do we work with these families of people who don't want services? And how do we help support them, because the clients or the consumers don't make that choice themselves? And I mean, it just says ensure that individuals with the most difficult to treat disorders are receiving services. If it's not their choice to receive services, I think we need to have that discussion too.
Does person-centered cover that situation, or do you think it needs more clarity?
for me, the bill got confusing when it was, because I think families will read this and have a concern, right? Like, why isn't this provider, this person helping my family member because I've said they need help, and we go in as the system or the, support services, however we want to define that, and we say, oh, they're choosing not to, and then the family is really frustrated because when we talk about access and we talk about care and we talk about where people get frustrated, it's the family sometimes more so than the clients who are really frustrated with the system. And the clients have a choice. And I think we need to be real about that.
Just to add that they don't always have a choice. People are often forced into services that they don't want on a regular basis. But I do think that that's important to consider. And I'm wondering if it would be better to word it something around access to services as opposed to like ensure that people are receiving services, that they ensure that people have access to the services that they choose, to get. Yeah.
Sorry, I didn't look at you.
Oh, yeah, no worries.
It's hard to tell
It came on really loud too, so.
But I just want to clarify, Christina, that you're talking about language in the bill versus language in the definition draft. Okay, I just wanted to make sure I wasn't confused. Sorry, someone on the phone was going to say something.
Yeah, this is Allison. From work on a different committee, one of the things that we were considering was the number of M1 holds that someone has. And, if they are becoming a danger to themselves or others, and possibly there is a time that someone needs services and they are not asking for it, but are we going to wait until it's mandatory because of, an altercation with emergency responders? I mean, there's a balance there, and I just don't think that we have it.
I'm going to say, okay, go ahead, Frank, because I don't have an answer to that. Hopefully you do.
I don't have an answer to him.
Well, I just wanted to bring that up as, a lot of times people don't want services because they've hit a level of crisis that's pretty dire.
My comment really is just about organizing the work again, and wondering if we can sort of think of this as, the task force has sort of oversight over the whole system, right? Behavioral health, large subcommittee focused on the safety net. We're here because of Senate Bill 222, and I think partly what we need to do is reflect the intent, not just to create a safety net so nobody falls through the cracks, but it does say, hard to serve. It does say severe. The intent is to keep people out of long-term institutionalization or jails, and that to me helps us set a priority, right? So the task force has a little bit longer timeline. June 2020, statewide. What does everybody need in Colorado in terms of a system? And for this, which is a little bit shorter timeline, it helps us prioritize, like for those people that fall through the cracks and fill up jails or end up homeless, how do we prioritize that work? To me, that it helps clarify a little bit what you're talking about, Captain.
Yeah, and I appreciate that kind of pivot a little bit because we have Senate Bill 222. It's there, right? What are we going to do with it, I think, is what the subcommittee needs to be really thinking about. So I thank you, Frank, for pushing us to operationalize. You get the flag for the day, because what does this mean to us? Like I'm sure everybody has more questions, and I'm sure that Camille, well, I'm not sure, I'm volunteering you, can be available in some fashion to continue to answer them. But what are we going to do with this, I think, is really at the heart of what we should try to come away with in this conversation. And I don't know if Summer, if you have thoughts to kick us off about that first question about alignment in the work of this subcommittee.
Yeah, I mean, I think the only thing that I would add is that, I think 222 it's a guidepost for us, right? So it's something that we can look at and refer to and say, this is our starting point. It's not necessarily the end all be all. So I think we can say as a subcommittee, what is it in alignment with 222 and what is it above and beyond 222 that we want to consider? It's not saying that 222 isn't already enough, but there's a lot to do.
Other comments on this alignment? Yeah, go ahead, Richard.
Yeah, I'm just a little curious too, because on our proposal, we have to develop a funding model to ensure the viability of the safety net system. That seems...
You are a CPA, right?
Yeah, that's why I'm asking the question.
Yes, we are tasked with that, and
Okay.
we will be looking at that
Well,
for
that'll
sure.
be interesting.
Yes, it will be.
Okay.
We're glad you're here.
Remember, you were each specially chosen, so. Other comments about 122 and our definition? I have a feeling we need to kind of work on it, or kind of round this out, this big amoeba that, you know, the first time we met, it felt just totally amoebic. And for me, I'm feeling like at least this is beginning to have some boundaries, as large as they are. But Frank is not the only one who's biting at the bit to dive a little deeper. But we want to make sure, because, you know, in any kind of problem-solving kind of exercise, defining the problem is really important, so that you know when you're done, you've solved the right problem. So we need, back there, and then, yeah, okay. So
I guess that just wanted to give some context. We put in the language around the intensive community treatment options into the bill, asking HCBUF and OBH to work together to see what constitutes a high-intensity behavioral treatment program, et cetera, to really look around that assertive community treatment, so that we're relooking at how we're engaging our community members who may be hard to serve or who are not engaging in treatment options, so that we don't end up having individuals with multiple M1s, that we are meeting them where they are in the community, that we're not expecting them to come to an outpatient appointment twice a week or something when that doesn't work for them, that we are enhancing programs that meet them where they are at in the community. We saw that as something that could really help us engage clients in a different way, so that they don't end up in jail or on multiple M1s, or living in a hospital emergency room, et cetera. So just wanted to give that as a side note. So
I just wanted to say I was really happy to read this bill, because it really specifies a lot of things I'd like to see. And I already have ideas when we get to that I think we need to put into place that would help get us there. And I'm sure a lot of you do too. But I was happy with this, and I think some of my interests, and I'm interested in more than just what I've talked about, but I think this gives us the guidance and the go ahead. So I just wanted to say that.
that's good. Other comments? Okay, while we pause, I did a faux pas, and I was really amiss, so I'm going to apologize to State Representative Young, who has been here with us and hung in there listening to our conversation. So thank you, Representative Young, for being here, and I'm sorry I didn't introduce you later.
No problem at all. You're doing wonderful work.
Well, we thank you for your support. Truly, it's really important to us, so thank you. Okay, take it away.
Well, those were kind of the questions we wanted to pose to you as a larger group today. And as you're reading 1 through 4, I mean, I think one that we didn't really get to were gaps or additional work that you see that you want to consider within the subcommittee that are not defined by 222. It's a big question. It's a lot to think through and spout answers to, but also maybe a place where we can get some information from you between meetings. But I don't know if anyone has thoughts they want to share about gaps that they see that, whether it be, I think some of them have been identified around language, making sure that we're just clarifying what these things mean. Some of those gaps they sort of clarify because we now know that they're inclusive of what you're asking about. But are there other gaps that you are concerned about that you want to make sure that the subcommittee considers in its work? Yeah, you might
go ahead.
You might want to come up to a microphone.
Yeah. Bill, come on. Yeah, and if you would identify yourself so we know who you are.
I'm Bill Hendricks with All Health Network. The one thing that I would encourage the subcommittee to look at, we've looked at person first language and defining severity and so forth. To my mind, the one word that we really need to define more is access, because I think that the problem that we have in mental health is that people may get that first access. If we define access as that a session with a mental health provider, that's great, but they don't get access to the full continuum of services that are needed to resolve their clinical issues. So I would just encourage the subcommittee to focus on what we mean by access, because I think that's critically important, and that's where people fall through the cracks because they don't have access to the full continuum of services that they need.
Thank you. I think that's really a good thing to be reminded of, that, you know, you can be seen at the emergency walk-in clinic or something and then get an appointment for 3 weeks later. So that's something we want to take a look at. Yes. No, we need you. Thank you.
I've been thinking about this of if we actually need a whole new subcommittee altogether around prevention. I don't know exactly what the children's subcommittee is all going to tackle, but that seems to be an important part on the continuum that I don't know if we'll have time to really tackle the way it should be, and if that needs to have a whole different subcommittee around prevention and prevention strategies, funding for prevention, and how that might be in multiple different state departments that may not be as coordinated as it should be. So just throwing that out there.
Excellent. Yeah, okay.
I would add two. I know that alternative options were brought up as we discussed in our group last meeting. But I do think that considering that if a safety net isn't something that works for all Coloradans, and it's not really a safety net, and knowing that clinical services and the system services that we have do not work for everyone, and the assumption that they will if people just engage is absolutely false. People need different things, and we don't have I'm not saying that we'll be able to get everything, you know, address all these alternative ideas, but for instance, I did some community meetings on racial equity and mental health this last spring, and one of the things that came up was for folks who are Native, Indigenous Americans, that not being able to have access to spiritual practices as a form of healing was a huge issue, and they didn't want those spiritual practices co-opted by system providers. That's not at all what they wanted, but just realizing that people need more than what I think we've even begun to comprehend, and I know we won't be able to get to all that, but just to kind of challenge the assumption that clinical services work for everyone, that everybody wants a therapist or will benefit from a therapist or a psychiatrist. I personally do, but not everybody does. And I think that's just really, really important to keep in mind if we don't want to end up just creating a safety net system that only serves the people with enough privilege to be able to find those services helpful, because not everyone has that experience or those needs. So,
good point. Kimberly?
I agree with Summer. I think we really need to look at that prevention side also, because if we can prevent these people from becoming in those beds or in the juvenile system, it's a key component to what we're doing. And that's where a key piece of public health can come into that intervention and prevention, as well as looking at that prevention and the prenatal aspect of it as well.
So we have a few comments on Zoom, and before I read them, I'm going to pause and see, Thomas, do you want to share your thoughts with the group, or would you like me to just read the comment that you had shared in chat?
Yeah, you know, I was just sitting here thinking about all that, you know, we talked about today, and the idea, using the word system in the phrase safety net system gives me pause. You know, the word system has negative connotations associated with it. I thought more about the idea of using the word framework. Framework is sort of a compilation of ideas and thoughts and beliefs, and I feel like we're trying to take the bill and translate it into its practical application. So I don't know, thinking that semantics, as we said earlier, you know, in our discussions it's important. And so I thought about that one particular word. And I have questions about how are we going to coordinate with the medical community. You know, I can think of individuals that we treat in the mental health systems that have concurrent medical needs that have a direct bearing effect upon their, you know, their personal mental health. And so I'm wondering how, you know, we're going to work with the medical community to balance that out. And I think we did a great job as a start as far as the definition is concerned, yet I don't feel like it does enough or goes far enough to really communicate what I firmly believe we're all collectively saying here, and that's the need for inclusivity. I can think of certain situations or circumstances that, you know, are not represented by the definition, at least not at this point in time.
And then we've also gotten a few comments related to the role that peer services may apply in this, as well as a comment that
yeah, I believe that was Amy.
Yep. And then also a comment that Section 6 cognitive challenges are not addressed, and that nursing home residents are often in need of behavioral services but do not qualify because of their dementia diagnosis.
That is correct.
Are there any other comments from the subcommittee before we move into closing?
I guess the only final thing I would say is that, you know, we have this big group looking at the whole state, but I don't think what we want to do is make something that is an overlay for every community. I think there has to be some kind of iterative process with each community so that we are responsive to the unique needs. Say if there's no broadband services and you're suggesting telehealth or those types of things. So I'm just hoping there's a way, other than, you know, each of us representing our own communities, that there's a way to get feedback as we go along from smaller groups rather than just this big idea for the whole state.
If I can just add, I think that's one of the reasons why we're so committed to having those community conversations and asking you all to get out in your communities and talk about the work of the task force, and especially as we start getting into those details of, this is what we're thinking about. Is this going to work in your community? How could it work in your community? I mean, we're really going to have to rely on all of you to help with that. So how this kind of started to gel with the overarching behavioral task force when we did a similar process related to their vision was that the statement of vision became something pretty succinct, like 1 or 2 sentences. And then we had these supporting components. I can't remember exactly what we called them.
We call them like principles or
organizing principles,
start to operationalize
which I think can capture some of these more specific pieces of language that support the broad statement. So we've been trying to collect them. I would encourage you to put them in the parking lot. I would encourage you to respond to our survey. It will be short and succinct. We'll make sure that it's something you can do within 5 minutes, so you can just answer some quick questions for us and get that back to us so that we can hear all of these things. And we'll be getting that to you in the next week so that it can be ready for the next meeting and we can start to really dig in. Summer, or Michelle, anything in closing you wanted to add? Okay, thank you for coming. The only other thing that I'll add that is a little off topic, but I need to put in a plug, is that this subcommittee has been a rock star example for our communications team, which is down there at the end. And we'll be trying to stop you again on your way out to get some quick videos. So if you all can be rock stars again, that would be fantastic. Yeah, you thought you were going to get out of here without a video camera. Be prepared to ask for autographs.
Right. Any other, we've got like 4 minutes or something. Any other questions, concerns? You know, I think it's important that we continue the conversation and continue the communication so that Summer and Stephanie and Emma know if you have something that you want to say. So can we take feedback from our, okay, you want to come up to the table so everybody can hear you, please? And tell us who you are again, because.
Is this on? Oh, okay. It's not exactly a question necessarily for this group, but I got an invitation to do the testimonies, and I am not particularly interested in doing that because my story isn't very compelling, but our membership of about 500 plus across the state, I would just like to be reassured that I can send that invitation out to the NAMI Colorado membership.
Absolutely, please send that out.
And then the memorandum of understanding, will that be available then for people who, so they understand how their testimony is going to be used?
Yes, absolutely. And I can follow up with you directly afterwards.
It'll be available at the site. Okay,
Yeah.
thanks.
Yeah.
Thank you. Yep.
Very good, thank you. Anything else? So we meet again in what, 2 weeks?
2 weeks on September 5th.
Okay, September 5th.
Is that wrong? Oh, I'm going to be so mad at myself. This calendar is killing me with all these subcommittees. We'll make sure you have September 5th. Thank you.
Okay.
It's 3 weeks though.
3 weeks.
Yeah.
Okay,
So
in
plenty of
3
time
weeks.
to do the homework in between.
Yeah.
Will we have new homework?
The survey.
Okay, just the survey, okay.
Yeah, I'm not making any promises that it's the only homework. I would expect that there will be more, so prepare yourself now.
Okay.
Yes.
Just real quick,
Yeah.
they're gonna, how do we know if they're gonna vote on anything that they need to wear? I wanted to touch base with another committee member and say, they're voting on this, can you vote for me? This is my vote. How are we gonna know if we're voting?
I'm just going to put it out there, I think at this stage of the game for our third meeting, we won't be having any votes.
Okay.
Yeah.
It's in the pharmacy building on the Anschutz campus, and we'll send parking details to you and directions to getting there. Parking is a headache almost everywhere we go, and we are really trying to make sure that we get specific instructions of places to park and directions into buildings. I feel your pain, though I have to say, if you haven't been out to Anschutz in the last year, it really has gotten better because a lot of the construction is coming to a conclusion. But we'll make sure that you have as much information as we can share about parking.
And maybe plan to try to get there by like 1:45, so you've got plenty of time. Then we can start right at 2.
All right, I think they were good. Anything else that you wanted to add, Nancy, in closing?
I want to thank everybody for your input and your thoughts. It was really a good meeting, and we're just going to keep going. So thank you all. And thank you, Michelle, for coming very much.